You don't know whether you were stung by a bark scorpion or overdosed on PCP? Well, I'm not going to ask how come you don't know that. We're going to figure it out ASAP. Do you know if you've had either or both? Are you saying that both happened to you and you don't know whether that's making you sick or not? Let me check you because you're not looking very good. You're looking a little bit bad. Let me get you checked in here real quick. Just make sure that you are okay. Alright, so you're having pain. You're having numbness and tingling in your hands? Okay. I do see that you have some jerky movement too. Can I see you walk? Let me have you walk. Okay. I'm looking for what's called ataxia. That's where your cerebellum isn't working. Don't worry, we're going to make sure you get care right away. We just got a really quick check and make sure we give you the right treatment for the right thing. Because the treatment is slightly different for a scorpion and PCP. Of course, we are in the Southwest, so the most common scorpion here is the bark scorpion. Right. Yeah, can I see your tongue? Go ahead and open your mouth. Let me take a look at your tongue. I'll just get my stuff. It's a good thing you found me here at my wilderness medicine camp. It's a very, very good thing. I'm just going to use my light here, the normal light that I use for your ears. Real quick, can you go ahead and open your mouth? Okay. What I'm looking for is whether or not your tongue is moving back and forth in what's called fasciculations. And I'm just going to keep monitoring here your vitals that the nurse got you hooked up with, okay? And I'm just kind of looking at those because sometimes they're slightly different. So what I'm looking for is your heart rate. May I also, I'm going to go ahead and put some hand sanitizer here. Okay. I'm going to go ahead and touch your wrists, okay? Both wrists. What I'm checking for is tachycardia. I want to see if your pulse seems fast to me, and I'm looking at the clock. And that's matching what I'm seeing on the machine. That is a very high heart rate. Your blood pressure is also a bit elevated. I want to double check that real quick, make sure that that's at the correct pressure. So tell me your story. Tell me what happened. So you don't know. Why don't you know? Okay. You were kidnapped and you just managed to escape. Wow. That's very impressive. May I have this on your right arm? Your right arm right here. I'm just going to buckle that up right there. Look at this beautiful. Tightening this figma right here. It's just that's extremely high, and I want to make sure that that's the case. It would make sense with both that you would have high blood pressure, but there's any number of other things that could have gone wrong for you during your time in the desert. Alright, so let me pause your talking for just a second. Crazy high. You're not exactly having a hypertensive urgency. You're not like above the 200s, but you are fairly high. And when I say 200s, I mean systolic. You would never have a diastolic pressure that high. A concerning diastolic pressure. Already 90 is concerning, and of course 100 is like you're looking at an emergency, especially in a pregnant woman. But you're not pregnant, right? That's perfect. Okay. So you were kidnapped. You may have been given a drug. You heard them talking about PCP. But there were scorpions as you were escaping your way through the desert. You're really thirsty. You have bite marks and you're not sure what it is. Scorpion stings are exquisitely painful. You would usually know, but if you're pretty delirious. So you also haven't had a lot of water. So we're going to give you IV fluids regardless. So fortunately for you, IV fluids are the treatment basically for PCP because we're trying to avoid rhabdo. And of course it'll help with your dehydration. So let's get a IV just hooked up to you real quick. I want one in each arm. We're just gonna, yeah, you can see the needle. It's not a big needle. It's not so big, don't worry. Don't worry. See, look. This is the needle. It's all sterile. Can you see it? It's a good needle. Alright. So we will just get that set up on your arm right here. Right on your arm here, and then I'm going to take a note of what time you came in. Okay, so we have all our supplies. I'm just going to put a tourniquet on this arm here really quick, okay? So I'm just going to wrap up on this arm. Okay, I'm going to take some alcohol and just wipe the side of your arm right here. And I already have my needle all prepped right here. You have beautiful veins on this arm, you really do. So, that's good. So we have the tourniquet, you're all cleansed. So now I'm going to just loosen this. Loosen this. So that the blood comes back in. And prepare for insertion. Not really loosening, I just don't want it to hurt you right here. Here on this side of your arm. Okay. You're taking the needle out of the package. We always want to make sure that the catheter can come out of the needle. The catheter is this plastic piece right here. Yeah, that's the catheter. And we're going to insert into the vein. And we always have the bevel facing upwards because it's easier for it to go through skin that way. Alright. We have blood, and now we put the catheter forward, not the needle. We take the needle and put the gauze here. Perfect. And we just have the catheter in. And now we release the tourniquet all the way. And then we're going to attach the saline lock. And hook that up here to this bag. And hang it right here. Same thing over here. Okay? See, that didn't hurt. We just got to get you. So what this is normal saline. Surgeons really like to use Ringer's lactate. That's also a good option. It's got dextrose involved, but we really want to try to keep down rhabdo. So I really want to focus on only fluids. What's rhabdo? Well, rhabdomyolysis is when your muscles start to break down because of the intensity of the PCP acting on them. So I'm going to finish my exam once we get this started, just because you also mentioned the dehydration and what I saw in your mouth. And I'm going to do a final check. I already have an idea of which of the two it is, and I'm going to tell you why in a second, but we're going to finish checking. I just want to make sure that we are getting you taken care of at the same time. So same thing on this side. We have our supplies. We have our tourniquet. We have our catheter. And over here, we have our 5 milliliters of normal saline. Right here. And we have our saline lock, we have our piggyback, perfect, alcohol wipe and gauze. Alright, let me see, the veins in this arm are not quite as good as this arm, but they're still pretty good. Let me see here. I'm just watching that arm, because it was so beautiful. Alright, let's put the tourniquet up top here. Perfect, perfect, perfect. Okay, we're going to clean with the gauze. I know it feels a little bit cold, nice and cool on your skin. And just make sure this tourniquet is exactly where it needs to be. Not really loosen, that was kind of the wrong word to use earlier, but you know what I mean. And then we're going to go ahead and insert the needle, bevel up. And make sure to advance the catheter, attach the saline lock, and then attach the IV basically. So get the IV up on here. Alright, that's also 1,000 milliliters of normal saline. Kind of help your kidneys to process everything you're going through. And the extra sharp is going in special sharp disposal. So even though we just have a 10 here, we try to keep everything pretty organized. Alright, so I'm going to really quick press on some of your muscles here. Just squeeze on your legs here, down here, here, here. What I'm watching for is what we call tenderness. Pain is what you report, right? You say that you're in pain, which, as you mentioned, coming in you are, and you do have that mark. Pain is what you report. Tenderness is what I observe as I'm like squeezing and moving around your body. Yeah, exactly. Exactly. I'm just going to kind of take some notes here on what we're finding. We want to make sure we at least have some kind of record for your PCM when you go back. So, have you been vomiting? Are you having some trouble breathing? A little bit? And I know, I can see you're kind of all over the place and jerking and like very, yeah, agitated. I can see you're pretty upset. Yeah. And that can be because of, you know, escaping a bad situation or because of one of these two things. PCP makes you very, very strong. And scorpion stings also make you very, very agitated. Yeah. May I listen to your heart and lungs? Try to take deep breaths. Feel the saline coming into your body. Feel it taking care of you. I'm going to do one more quick exam, and then I'm going to tell you what the plan is, okay? I just want to listen to your lungs, okay? So I'm going to listen here in the back. Take a deep breath in and out. Again, do your deep breath in and out. Deep breath in and out. And then again, deep breath in and out. And again, deep breath in and out. Deep breath in and out. And over here, deep breath in and out. I'm gonna have you, while we were over here, right, we took a little blood sample. I'm gonna have that down at the lab, and then we're gonna know for sure because you can pick up PCP on a drug screen, okay? And we'll also check for anything else. Any other kind of assault? No. Oh, you're an adventurer. Oh, pirates. Sand pirates. Are you having any psychosis? Are you sure that that is true? Well, look at that. There are reports of sand pirates in the area. Even before the drug screen comes back, I think I know what's going on with you. May I just see your eyes real quick? Just one big ball. Okay. Alright, sit tight, my dear. I'm gonna put in some orders. So your pupils are normal. Yeah, your pupils are normal. That's important. That's very important. I'm just gonna write in some of this good stuff. Are you feeling a little blurry? Yeah. So your eyes are moving back and forth like this, and your tongue is doing all kinds of stuff. That's pretty consistent with a bark scorpion sting. Yeah. Your walk, you didn't have the kind of like uncoordinated, like you're like jerky, but you didn't have like the uncoordinated, like what we call an ataxic gait that you would see with PCP. And you don't seem to be having psychosis, you just seem to be angry and agitated, which I totally understand. It's okay. And I don't mind that you swore when you came in. I get it. It happens, people. You know, you're stressed out. So, you know what the big difference is, though? Even though you're dehydrated, you're like salivating too much. Wet hypersalivation. That's very consistent with a scorpion sting. Yeah, with PCP, it's all dry, and your eyes are all constricted. Mm-hmm. Yep. All right. I'm gonna just get some good orders in here. So PCP has some kind of cholinergic behavior, but primarily it's an MDA receptor antagonist. MDA is your what helps all of your nerve cells kind of have any kind of memory or plasticity. It's a really important thing. Yep. All right, so we are going to watch you for a little bit. There is something called Anascorp for scorpion stings. Because it's not really made anymore, it's extremely expensive, and we want to reserve it for the most severe cases. You feel severe and awful right now. We are going to ask that they send us some to have on hold in case we need it. All antidotes or antivenoms carry with them the risk of anaphylaxis. Scorpion stings themselves can cause, a respiratory collapse, right? Because it's a neurotoxin, so it can affect that. So if we need to ventilate you, we will, okay? I know you're young. We're going to take care of you. You're not going to get into that situation, okay? We're going to give you some benzodiazepines to calm everything down. Slow your heart rate, slow your respiratory rate, keep you from having all this hypertension going up to your brain, okay? So, benzodiazepines are fairly strong medications. I'm going to give you some fast-acting ones that'll calm you right down, okay? I'm actually going to put some midazolam right into your IV. Yeah, exactly. Well, so there's another one. Let me just... get my gloves back on here. You didn't see my gloves before because we have new, almost invisible glove technology. It's pretty impressive. But of course, we always have gloves on when we're doing our IVs and such. So here's the deal. I'm just going to add some midazolam, but for anti-seizures, like with PCP, we might use diazepam. So, PCP is treated only with the benzos and the IV. You're getting the IV because of dehydration, not because of PCP, which I'm pretty sure is going to come back negative. Okay? Does that make sense? The benzos that I'm giving you, instead of diazepam for seizures like in PCP, I'm giving you just a touch of midazolam to kind of calm you down, make you feel a little bit better, because that'll also help you think clearly with any decisions you have to make. Do you have any kind of restrictions, like do not intubate or anything else like that that we need to know about? Do not resuscitate, anything like that? No? Okay, perfect. Just important to ask and make sure that everything is in order. So, we're going to watch you for a little bit. Mm-hmm. Well, and your breathing is pretty fast. We're going to get you evacuated, and that's what I'm trying to coordinate now. So, I'm also going to get some oxygen hooked up here. Here, just take this right under your nose. It's called a nasal cannula, just to make sure you're oxygenating. And gonna turn this up. So what I'm coordinating now is your evac. You should be watched in a ward that has mechanical ventilation. Here we don't have mechanical ventilation. We would literally have to back ventilate you. And our sedatives aren't strong enough either. So we're going to get you out. So it's very important. So yep, you should be feeling the effect now of being a little bit calmer. Look, if we need to intubate you, we will. Wait, what do we intubate you? If it seems like you're not oxygenating, like if your oxygen sat is starting to drop, you know, you're going 94, 86, like you're moving down where you shouldn't be, 70s, 60s, we would start with non-invasive things first, like oxygenating. In other kinds of respiratory failure, I might even add some albuterol to open up the lungs. Yours would be because of nerves, so probably an anticholinergic would be more effective, and I might use that. That's what I might do. But in general, we would intubate when you, like, give me just a second here. I'm getting an answer back from the emergency. Folks. If it feels like your airway is going to close, basically, or your oxygen is going really down, you're not rising and falling your chest appropriately, you start having like a lot of retractions and you look like you're in respiratory distress and can't breathe. So what we would do is we would rapidly put you like unconscious. We'd give you some medications that kind of Yep. So basically you do like a paralytic, kind of like succinylcholine. That's kind of an old one. We use other things now. That's kind of based on the curare medication that people used to shoot at people to paralyze them, and then like antitamate to sedate or induce, really not sedate, like induce you, like get you to go all the way to sleep. Yeah. But we would make sure you have a lot of oxygen first before doing something like that. So. They're starting to feel calmer. That's good. I think you will be okay. I do. Just open your mouth again. Okay. Nice deep breaths for me. I'm looking at your vitals here. Pretty happy with that. Pretty happy with that. Absolutely, yeah. Well, yeah, that's what I would start with. Exactly. Oh, I like the sounds of keyboard too. I don't get ASMR from it, but I do like it. Absolutely. Yeah, there I can certainly. I know you want to stay in this camp and keep having adventures in the area, but you know, scorpion sting is serious. I know it's exquisitely painful. That's another reason for them to definitely am on board. Well, they're going to send the anoscorp here. We're going to have that on hand. I really think that you're going to do okay with what's called supportive management. Yeah. Because we don't want to put you at the risk of anaphylaxis or other things like that when, you know, you're already having difficulty breathing. But as we start to notice things going downhill, if we're a severe case, if we're starting to have to intubate you, then absolutely. And of course, that doesn't mean your case isn't valid or important. It certainly is. It's a good thing. It means that you have a higher chance of survival right now. You're not likely to need to be intubated and need the anti-venom, basically. You're definitely worth it. You're definitely worth the cost of anoscorp. So I hope that answers your question today. It does appear to be a scorpion sting, and the trick is in the wet mouth. And in kind of the agitation instead of psychosis, you're having the eyes moving and the tongue moving instead of having the trouble walking. Those are kind of our common indicators. And then your pupils are not really, really tiny. So, well, the test will be back in just a little bit. Alright, I'm going to sit here and keep